Okay.
Okay. Hello, Sal. Good to see you again.
Hello, everyone.
Good to see you.
Good morning and good afternoon.
Yeah, exactly. The whole time frame again.
Good morning, good afternoon.
Yeah. Daniel just opened the webinar, and we wait a couple of minutes until all participants are online.
Already joining. Very good.
Yeah. Renato, do you have, how do you wish to start with a presentation, or would you prefer?
I have organized a PowerPoint presentation. So it's 15 minutes, right?
Yeah.
Yes, you can, as long as you take Hi Sal. Just for your information, we just thought that we would start with Dr. Ambrosio and then.
Really?
Okay. We're just going to take a few more minutes. And share my screen to our participants. Okay, I think I'm going to do one more minute and then I'm going to do the introduction and then we're going to start with the meeting. Already some people using the chat. Hi, very nice to meet you all.
We see good morning, good evening, as it is from all time frames. Renato, did you do a lot of webinars during the Corona situation now?
Probably about 100.
Great.
I am very good with Zoom now. I can help a lot with Zoom.
Perfect.
I think we need to start with the meeting. Ladies and gentlemen, thank you for joining our second EI user meeting. Before we start, I would like to introduce myself. My name is Saleel JIVRAJ and I'm a sales manager here at ESW Vision, and I will also be your moderator today. And then I would also like to welcome Petra Bruckmüller, our president and CEO. And then, of course, our special guests, our speakers today. Today we will be having 4 of them. We are going to start with Dr. Renato AMBRÓSIO, joining us from Brazil. Then we are going to continue with Dr. AKOVA from Turkey, Dr. MOREIRA from Brazil as well, and then Dr. JIVRAJ from Canada. Hi to all of you and thank you for joining. Some quick general things before we start. The user meeting is going to take...
Just a second, Daniel. Daniel, there is a strong interruption. Maybe the others can switch off their, put on mute the micro, because we have a strange noise. Okay, no, sorry. Okay, move forward.
Just some general things. So the user meeting is going to take 1 hour. And I would encourage all of you to ask as many questions as possible. You can also use the raise your hand button of Zoom, so I can activate your microphone, then you can ask your questions directly. You can also use the Q&A function and of course also the chat. And yeah, I would also ask you to contribute and I wish you a very pleasant second user meeting.
Yeah, also from my side, a short welcome to this second user meeting. We are very happy to welcome our speakers from different regions worldwide. It's our great pleasure that we have so many EI users, mainly EI users today on the panel, on the participants, as we are since 4 or 5 years now on the market. But as you can imagine, being a manufacturer and developer of a device is one part of the game. The much more exciting part is then to share experience from practice user, from specialists, and also the expertise from our speakers today. So very welcome, warm welcome, and to start with Mr. Dr. Renato AMBRÓSIO, live from Brazil. Thank you.
Thank you. Well, it's a pleasure to participate in this webinar. I hope you can see my slides. And You know, current perspectives on dry eye syndrome, I was thinking, what should I bring to present to you about the care we do today for patients with dry eye. And I think the first major concept is to understand what dry eye is today. I just saw a patient here at the clinic. She comes as a contact lens intolerant, and one of her complaints is tearing. She has tearing. Her tears come down her face. And after listening to her, I told her, you have dry eye. And she looked at me with a face that, have you listened to what I just saw? I'm tearing. How tearing is dry eye? So we have to give the patient education and understanding the multifactorial disease that categorizes the ocular surface in terms of
şu Zoom'da şeyi nasıl
suffering.
yapıyorum? Ses ve şeyi yapamadım. Sesini duymuyorum. Benim sesim.
Well, and this is important to get the inflammation down, understand the neurosensory abnormalities and hyperosmolarity. So patient education is first, and patients should understand about the tear film quality, and understanding that in a second, they jump into the conclusion, okay, so I have tears, but they have bad quality. So they have less stability and they have dysfunction. Is not true dry eye. That's why I say dry under ASPAS. So patients should understand the types of the disease is not just academic. We should tell the patients about ACUS, which is the true dry eye, the Sjogren's syndrome. But the part that is making us evolve in terms of the treatment is the evaporative dry eye. And I would love to hear the experience our colleagues are having with the true dry eye, because even Sjogren's syndrome is benefiting with the treatment for the evaporative dry eye. They are doing better. Not all of them, but they should understand they have some options to treat. And probably the inflammation on the true dry eye related to the treatment that we are doing can improve. So it's a management that eventually goes into the systemic domain, because there are drugs that people should use that affect dry eye. And this is a classic graph that half of the cases are evaporative and 36 are mixed. I would say that probably this true AQs will go down. This would increase the number of mixed cases, because I think some of the AQs that are related to the rheumatologic disease will be going up if we consider also the impact of medication. So drugs, and this is very important that our colleague and friend Jose Gomez were the leading scientists on the iatrogenic report, and we have drugs, systemic drugs, and also the topical BAK, of course, contact lens, surgeries. This is the surgical corneal procedures for refractive surgery that cause dry eye, and eventually some other situations like graft versus host disease, which should be always in our mind. Those patients need a lot of help. I was fortunate to be in Seattle with Steve Wilson when he published the first cases of dry eye related to the neurotrophic epitheliopathy that is related to dry eye. That is in fact not dry at all. This is a high Sherman testing, and this neurotrophic epitheliopathy goes into the understanding of the role of neurotrophic factors for the ocular surface. So this was a few years later, we published this strategies. And one of the things is that we have to screen these patients at higher risk for problems after laser vision correction. So this patient, in fact, she had some meibomian gland dysfunction, and she comes asking for LASIK tomorrow. Actually, that's what she wanted. I know I have to be out of contact lens. I'm out of contact lens for about a week. And if possible, I want a surgery tomorrow. This is not the case for her. Probably another clinic would do that, and eventually she may be fine. But we need to understand that she's at high risk for severe dry eye after surgery, and we should have a strategy and treat her to improve her tests. We have to understand the clinical evaluation, And it starts with a good patient complaint understanding, systemic conditions. This case, for example, she is very healthy, and we have to go into the domain of more tests, understanding systemic medications. The whole eye exam should include ophthalmic imaging. And this is not exactly that patient, but very similar. This a patient that was seen a few years ago with inferior stiffening, and a lot of patients come because of the fear of contact lens related warpage versus keratoconus. And she had, this is the keratograph 5, which gives you the opportunity to non-invasively do the assessment of the tear stability and with all the imaging and also the meibomian glands. And this is the patient that I just showed you. We have the tarsus. And if you see this image, now you can see that with a regular slit lamp, we have the opportunity to see the glands. So when I ask my colleagues that are cornea specialists to look at the glands, they look at here. And eventually here we have some signs of inflammation and meibomian gland disease. We have the part that the glands is not leaving with a good meibum, but the glands are here. And eventually with better care on the slit lamp, you can look at the slit lamp and understand that. And we have protocols to improve this. This is another case that we had the right and left eye, and you see the glands that are, this is the left eye. I don't know what happened with this slide, but you see the regular slit lamp, you can see that. So multimodal imaging is important. Eventually we will come with more artificial intelligence to optimize and make our efficiency on the diagnostics for ocular surface, as we are doing today, for example, for keratoconus. And eventually this patient was not actually a warpage, because you see the tomographic and biomechanical integration, it's 0, even though she has abnormalities on the surface, but she had dry eye, and we have to break the cycle. And that's a very similar situation that I saw today on a patient that comes with contact lens intolerance for refractive surgery. One thing that I like to highlight is the importance of, we are evolving to a more specialized medicine, and with osmolarity, you can really improve our understanding about the ocular surface. And in terms of treatment, we have from patient education and omega-3 that every patient should have. We can customize. Omega-3 is very important. Artificial tears is a misnomer. Plugs may help, but today we have IPL. And IPL, I would say, is one of the main parts of the treatment, because it helps. This is myself having IPL, and I have a little bit of my meibomian gland dysfunction. I would say everyone would have a little bit of dry eye, and this type of patient education is very important, so that they should understand what is IPL and what's the regular, the post light that is regulated. They should understand it's not laser. Of course, we have to be careful, especially in Rio, because we have a lot of sun here, and we have a population that has a lot of mix in terms of the Fritz-Perry grading scale. So sometimes it's very challenging for us to say which grading is each patient. But I would say that Farid Thanos, who works with me, she's very keen on and careful with the indication for that. And I would say about 85% satisfaction is a good number, because it gives a very reasonable expectation. But I would say we can go even higher than that if we improve patient selection. And eventually some patients do very well in the first 2 treatments. They don't come back for the 3rd treatment. And eventually some patients may benefit from a 4th. Best indications, we are always learning. I have my understanding that we are in this planet to evolve, to be better and better always. And understanding the best indications is one of the most important parts of this very interesting new area for ophthalmology. And evaluating clinical benefits, before and after surgery, that the tools should be where we can optimize our treatment. And of course, patients should understand supported treatments, you know, hygiene, the omega-3 supplementation, and tears will be also important. So we need a clinical protocol. The protocol includes a complete ophthalmic evaluation. Tear osmolarity, we would love to use it more, but it sometimes does not work as predictable as we have, but we may have opportunities to improve here. We have questionnaires. Questionnaires are very important because the questionnaires make objective the symptoms. It's turns symptoms and signs. And of course, we should look at the literature, and some of these reports should be always in our mind when we counsel these patients. And so today, we have new concepts for the diagnosis and treatment. This is very important for any case, but if you do refractive surgery, this is probably one of the most important areas that you have to be careful. Many studies have shown that the major factor for dissatisfaction is dry eye. And if we have education so that the patient understands they have dry eye before, they have to treat their eyes before surgery, and they will be much better. And of course, the procedures and the evolving concept of the dry eye spa, which I think it's better to call a tear spa. It's not a dry eye spa, it's a tear spa. And this is the slide of the Violet June, which is a campaign about keratoconus. But I would say that today the Tukes July is probably what we should use to promote dry eye in terms of patient education. So thank you very much for the attention, and I look forward to more discussions.
So what I was taking from your presentation is that you are really think diagnostic is very, very important to select the right patients and to know which kind of treatment that suits them.
Absolutely. Diagnostics starts with good anamnesis, listening to the patient complaint and history. And of course, we need the imaging tests, like your tests, like keratograph tests. We need diagnostics to fundament the indication for the best, to customize, to personalize the treatment for each patient. You are in mute, Petra.
Yeah.
Renato, how many patients did you already treat since you were working with EI? What do you around?
That's a good question. I have to ask my colleague Faridi because she's the one who handles, but we have a few hundreds now.
Yeah.
And we have to prepare some of the data for some publication because we have been doing it for some time, and eventually this is important. And one of the things that we always struggle when we think about the scientific communication is data. And so the reporting of the improvements, we don't have a very good metric. The tear film breakup time would be a good metric. The questionnaires will be a good metric, but eventually we need probably a meibomian gland score so that we can see that, really see a number for that. But we are very happy with the treatment, and I think the concept of the tiered spa is probably the main message that I would say, and it includes a mind shift in terms of understanding what is patients with dry eye that are very sick, and everybody that will benefit from this type of treatment.
Yeah, I totally agree, and I think it's a very good and a very impressive message, because it's as you mentioned, you are a doctor, of course, so you see patients already suffering. But I think you agree, the earlier stage patients take care about their eye comfort by doing something in advance to take care about, with an eye spa, with a tear spa, it's something different than to be already in the stage having a treatment, because it's already the final severe step. You're right. So I don't know, do we have, yeah, here we have questions.
You have a question. Can you comment on the benefits of the regulated IPL, so the benefits of EI compared to other forms of treatment?
Oh, absolutely. Well, that's the part of education, value. And I think I would love to understand more about the futures, for example, because we don't have the perfect understanding of the future. But once we have a control of the energy, we have the benefit. And a lot of colleagues, they come to say, and I have here in this building, I am in a very big building in Ipanema, and we have probably a dozen of other colleagues that do dermatology. And eventually some of them, they use IPLs. We have a cosmetic down the floor for, they have IPL. What is the difference between IPL and IPL? Is they're regulated. So the regulation of the energy is critical for the success of the treatment. And I would come with a very interesting quote. What's the difference between medicine and poison? Is the dose. Is the dose. It's simple. It's simple. We need to get a proper dose. The proper energy it has to be optimized for the benefit, for the clinical benefit that we want. And pulsed light is a huge spectrum of treatments. You have different filters, you have different energy protocols, and if you change that, you change completely the result. And it's important to understand that it's not laser. Laser is easier to use because laser is only one wavelength, is coherent. IPL is a huge energy that has to be controlled.
Exactly. I couldn't explain it better. Great.
Oh, thank you. I learned a lot from you, Petra. Thank you very much.
No, it's for us definitely always a pleasure, and I know Gustavo is also doing here a lot of support to bring all the new informations or new experience also to Brazil and to exchange, have the opportunity to exchange with you using the devices, because it's something very beneficial. And I think as we installed here this, we set up this second user meeting, we definitely plan to do something like that regularly every month, only to share these feedbacks. And sometimes I know from Gustavo, who often comes with very interesting questions from your colleagues of with feedbacks, having experienced some very certain outcome of the treatment, not knowing in our protocol that this would be a benefit, but all of a sudden it appears as a benefit. So it's always interesting to exchange here and to hear lots of those feedbacks who are very impressive.
I think before
I'm reading here, the question is, what empirical evidence is there that there is a better therapy than the older tech? And this study, I was kind of very fast that they did a mask, so the treatment was blocked. If you read this study, is a very good evidence on this, the benefit of the good regulated IPL. If you don't have a proper energy, you won't have the result. But of course, is that the best energy as possible? I'm sure that that are more to come. And I can read Petra's mind and Daniel's mind that they have some other future things that will probably improve our ability to help our patients, because this is definitely a huge area of work.
Yeah, the energy, you are right. The energy is always a point which is a very important parameter in the outcome of the treatment. But we are here very proud to say that it's the 4 parameters normally are combined in a pulsed light technology, like the filtration, duration, the wavelengths, the energy. All of them, different suppliers try to reach the main benefit like EI. But as it is not only to bring those 4 parameters in the perfect shape, it's also how to transfer the light. Because very often other suppliers are surprised. We are using a train of flashes, combining 8 different flashes. And with most of the devices on the market, you would immediately burn the skin of a patient if you combine in milliseconds those flashes we transfer. So it's also part of how it comes to this effect. And here we worked on this, as you know, on these neurological studies, which have been the base of our development, to say, okay, it's if you arrive to transfer the right wavelengths in the right spectrum of the pulsed light, but also in a very close time frame, you have better benefit than if you put flash by flash, even if you take the same energy, because we know many suppliers tried already to use same energy. But the smile in our eyes was I think, maybe as we know now together in the dry eye spa or dry eye management, with the right evaluation of a dry eye patient, and also to evaluate immediately the improvement. That's something very exciting. And here we have really fun with the smiley device backside of Daniel with tear check. And I hope you will very soon discover also in Brazil once this device comes to your hands.
Yeah, I remember my colleague and friend from Italy, Luca Gualdi. He has an excellent experience with the IPL, and he tested all of the machines, and he provided me his experience and helped me a lot to go forward with your machine, because he explained me that the benefit and the understanding about the energy and the treatment is like you have a very important and very good weapon, but how to use that tool to improve the patient care, that's a complete different thing. So you have to, and that's why I do believe that the expertise you have is good. Of course, we could be more versatile for treating other things with IPL if we have more, opportunity to change the filter and etc. for doing other types of treatments. But for the meibomian gland dysfunction, excellent optimization is really critical. And eventually it's one size fits all because it's really optimized.
Yeah.
Does anyone like to comment on the presentation of Dr. Ambrósio, or on anything that was said? Otherwise, I think we would continue with Dr. AKOVA.
Yes. Hello.
Hi.
Hello, everyone. Hi.
Do you have a video also?
No, I don't have video.
Okay.
Let me go.
It's on the left, down in the corner left on the bottom.
Just a minute. No.
Do you need assistance?
It might be, yes. Just a minute.
There is a share screen green button in your screen.
I did.
Just click there, and then it will open a window so that you can see which you want to share with us. We have all the screens. Good.
Yes, perfect.
Yes. Hello, everyone. It was very nice to listen Renato. He did a very nice, extensive coverage. What I would like to do is to share our experience in a small subset of patients with IPL. We did this winter, just before the pandemic, a group of patients IPL treatment. To begin with, is as you know, dry eye disease is. Do you see me on the screen? No.
We see your screen, yes.
We see, yes, we have your presentation on it.
No, my view.
No, but unfortunately not.
Your video is stopped. You have on your left down, you have mute and microphone and your video. You just click.
Oh, okay, let me do that.
So you change the view of the screen.
Okay. Let me show my slides anyway. This is dry eye has a significant impact on the quality of life, as all we know, and the evaporative type and mixed type is very important in terms of the this IPL treatment. We used either serous meibography and non-invasive breakup time system in our patients, and also we used the IPL is another system with top cone photography. In our patients, let me go to directly to the study. We used the intense pulse therapy in a subset of patients with severe meibomian gland disease and acne rosacea patients. And these patients were treated with all available treatment in terms of medical treatment, topical and systemic. And we included 21 patients followed 6 months with maximum oral and topical treatment for posterior blepharitis and showed improvement, but it was not enough. And these patients underwent IPL treatment for day 1, day 15, and day 45. And we looked at non-invasive breakup time, tear osmolarity, Schirmer testing, meibography, and lid margin abnormality scores, as well as meibomian gland expressibility. And we evaluated the conjunctival and corneal staining, of course, and we did the ocular surface index questionnaire, as well as speed and subjective remission from none to complete remission. We evaluated these all parameters at day 1, day 15, and day 45, and we compared to baseline evaluation. Our patients were comparable all patients with a mean age of 60. We included 12 males and 9 females, and 19 of our patients, 4 had acne rosacea, and 16 of our patients received systemic therapy, either oral azithromycin or doxycycline. And all patients received topical therapy, including lotoprednol and topical antibiotics, mainly azithromycin, artificial tears, and topical cyclosporin, either in the form of 0.5 or 0.1, 0.05 or 0.1. And when we looked at the our patients' data, these are the tear osmolarity at the baseline. The osmolarity was not very high compared when similar to meibomian gland disease. Non-invasive breakup time was 7, and these are the other scores. And this is the speed test, and is upper and lower lid LMA and MGA were seen in this slide. And this is the baseline values. And then when we looked at the day 45, there is a improvement in all areas, but not all our statistically significant. Osmolarity was improved a little bit, and meibomian gland appearance was much better. And when we looked at the meibography from baseline to day 45, there was some improvement in the upper and lower lid. They were almost similar. Schirmer testing was a little bit, it was 13 to 12. It doesn't that much different. For conjunctival staining, it was better, and OSTI scores was much better. And when we looked at the TMH, this was also much better. In this group of patients with severe disease, as we call as degree 4 in all patients, IPL was effective in terms of improving tear osmolarity, breakup time, especially meibomian gland expressibility, and corneal and conjunctival staining and subjective tests. Symptoms were reduced in 100% of our patients, and it's difficult to call complete remission, but they were very happy in all of them, and 80% said they had much better and needed less treatment, and we did not see any ocular side effects. As far as the mechanism is, as you mentioned, previous speaker, this is the local warming of meibomian glands and melting of thickened meibomian secretion. This is also effective reducing the bacterial and parasitic growth on eyelids, as well as reduction of pro-inflammatory cytokines, including IL-17 and IL-6 in tear film. And there is also photomodulation effect and improvement in micro and microstructure of meibomian glands. I thank you for your attention, as this is the summary of previous studies. In conclusion, we think is the in resistant posterior blepharitis patients, this therapy may help to decrease symptoms of our patients and improves most of our ocular surface parameters. But this is, of course, is a limited number of patients with severe disease, and my experience in moderate patients get help a lot from this therapy as well as refractive surgery patients. Thank you for your attention. I am happy to answer your questions.
Any questions from the audience? Now your video is working.
Yeah, sorry.
From the audience or from our other speakers? Renato, I think your microphone is muted, and Petra as well.
I asked everybody and I forgot myself. How long, may I ask you, how long do you still use the EI?
Pardon?
How long do you already use the EI?
Actually, it's almost a year now.
Okay, great.
And especially at the beginning, I was a little bit not pessimistic, but very, I wasn't sure if it's effective, but especially when I use this subset of patients with severe disease, I was impressed, I should tell, and it's working quite well. Especially it works better in moderate patients, but with these severe patients, we were very happy, especially with the subjective findings of patients, with their happiness, I would say.
Yeah, and for these severe patients, did you add a fourth treatment?
With these patients were treated with all available treatments. You know, systemic antibiotics, massage, compresses, cyclosporin, steroids, artificial tears, antibiotics, everything. This was like last resort. We picked this subset of patients and then we treated them. That's why it was a difficult patient group. I mean, they were desperate. I mean, they get help from the previous treatment, but IPL had an additional help to these patients. And some of them, after this, asked for repeated therapy. After 6 months. They said, oh, it helped me a lot, and I think I should have treatment later on. Not now, but later on.
Yeah, that's also a very interesting part, always to have this regular maintenance treatment. As you know, one single maintenance session is normally enough to continue the successful result and the benefit for the patient to extend therapy.
Yes.
Great.
Thank you.
So I think there's a question for Dr. AKOVA. Oh no, it's another. Okay. So I let Daniel, if something.
Yeah, in the meantime, started our short survey. And of course, we know that being female is females tend to suffer more often from dry eyes, and although our sample, I would say, is not that big here, in our survey, it also shows that 66% of the people using an EI treat female patients more often than male patients. I think that's quite interesting. And we have also a question regarding the diagnostic, how important diagnostic is. And here also the answers are almost unanimous. Most of the people think it's very, very important to diagnose properly. And if you also think it's important, but there are no people thinking that it's not important. So I think we did one thing right in developing a tool especially dedicated to the diagnostic of dry eye, yeah, and to the analysis of the tear film. Okay, let me shortly stop the survey. Are there any questions, any other questions? Okay, if not, I would suggest we continue with Dr. MOREIRA. I'm just going to promote him to the panel.
Oh, all right. Are you seeing me there?
Yes.
Yes, welcome. Hello, Dr. MOREIRA.
Hello,
Nice to
everybody.
meet you.
Good morning and good afternoon, and maybe good night to some of us. Now, I will start sharing my screen. Just give me a second here to find the right screen. Right here, share. Okay, you're probably seeing my name now, right?
Yes.
Okay, now I first like to thank the invitation, the kind invitation of all of you guys, and thank for allowing me to participate in this discussion. I'm Hamilton Moreira from southern Brazil, Curitiba. That's much southern than Rio. That's Renato is up there in Rio. I'm southern here in Brazil.
Hamilton, can I for a second? There's one window. It says build order. That's kind of blocking the screen that we see. A little bit.
Can you see the screen now or not?
Yes, but there is one window blocking parts of it. I'm
There's
not sure.
Another window.
Yeah, it's
in the middle.
Build order on top.
Let's see what's happening here.
It's the small one.
How about now? Is it still there? Another window? Stop share. Let me see here. Just give me a second.
Yeah.
What other window is there? Let me see here. Close these other windows. Close all other windows. Now I have only two windows open, so let's see if that's going to happen again. Okay, let me see here. Share screen again. And my window is here. And video play. Is it still two windows there or only one now?
It's still two, but I think it's only a small part, so it doesn't really, it's not that important.
Are you going to be able to understand what I'm saying, or we are just speaking to the clouds?
No,
Okay, can you follow it? Okay, let's try to do this like it is right now. If you cannot follow what I'm saying, then you just interrupt me, please. I'm showing here the clinic that I work with. There are many buildings. And what I would like to show with this slide is that it doesn't matter the size of your clinic. You have to think about your competition. You have to think about the others in your city. And all of us, absolutely all of us have competition. And when you think about competitive strategy, you have to think about positioning. And positioning can be thought as choosing the right pound. So if you are in the right pound, you have to look in your clinic. If you are in the right pound, then you must think about IRL. The posted light is something that must fit into your clinic, and you have to think if you are the right pound. So there are many things in your company that you put into, you spend a lot of money, but the patient does not perceive. So there's a few things that you can call as drivers, and your competition is going to do the same thing as their drivers. And of course, since we share the same business of ophthalmology, you have points of parity. And what you want to see if the pulsed light is going to fit into your company as a value that you're creating to your customer. You have to create value with this machine. So you have to set up in such a way that the customer is going to perceive that. It's very important for you to have success with this machine. Otherwise, it's going to be another piece of equipment that's going to be standing there, you know, and doing nothing. So, of course, many other doctors say that with warm compresses, I can reach the same results. Absolutely impossible. Your patient is not going to perceive warm compresses as creating value to your company. Warm compresses, ocular lubricants, and lead hygiene, if you go to the publications, you might have results that are similar. And of course, if you're going to use this machine, this equipment, you're going to see the results are better. Yes, they are better. But any kind of a discussion that's going to compare with warm compresses, it's unfair. It's not the same thing. You're talking about two different businesses. You're comparing oranges and apples. So whenever you think, oh, I think Renato AMBRÓSIO, he is the one who taught, we used to call dry eye spa, okay? And I think Renato told me to change to, I'm not sure, to tear spa. So you have to think about this as a driver, as something in your clinic that's going to promote your clinic among your city, your patients. And to be a driver, you must have reliable results, good results. Most of the patients that are going to be under this procedure has to come out as better. Useful, I mean, it cannot be just a piece of equipment sitting there and doing nothing. You have to have certain number of procedures to worth what you're investing. And affordable, and when I say affordable, is affordable to your patients. It must be affordable to your patients. And then you have a driver. Well, I'd like to show one example only of a woman who came, she's in her 70s, who came into the clinic with this meibomian gland dysfunction. And she was a candidate for cataract surgery. And the routine pre-op topography showed this high irregular astigmatism. I want you to stop a little bit, understand what I'm trying to show here. She was, average K was 47. And see, are you able to see what I'm showing here? I'm not sure. Yes. Okay. So the average K was 47 and cylinder was irregular astigma of 4.3. On the left eye was not different, a little mild, a little less than the right, but was still a striking picture of irregular astigmatism and high Ks. And well, you have the slit lamp picture, you have the breakup time, and you have the topography now. And then we sent her for the pulsed light treatment, and 45 days after, she came back like this. And she was a candidate for this multifocal diffractive IOLs. So we found a 2 diopter difference in the average K and a 3 diopter difference in the cylinder. And on the left eye, the picture was just the same. So now imagine if you're going to use this K for measuring the IOL, or you're going to use this real post-treatment K and see what is this difference. And take a time here and think that this is a striking extreme case. But think a little bit as how many patients like this come into your clinic asking for IOLs, usually over the 60s. And many of them want to get rid of the reading glasses. And you know, it's very hard to get the right case. And you don't pay attention to the tear film. You don't pay attention to what is lubricating the cornea. So this is something that's now improving a lot our care of cataract and refractive surgery, as Renato showed us before. This is what happens. This is a scanning electron microscopy that I've done many years ago when I was a fellow. And this is irregular, right? But this is a living, actually, this is not a living tissue. This is a donor cornea, but This is the living tissue that's, is showing what happens. The wavefront passes through that irregular surface to get to the IOL, to the diffractive IOL. So what we found now is the OCT, the corneal epithelium map of the OCT, is another aid to indicate, to properly indicate the pulsed light. We are seeing patients such as this with a very mild irregularity on epithelium, and this is something that now is improving our ability of correct indication of the pulsed light. And I find this very useful now. Our results are not different from the literature. About 5% of the patients, they almost want the money back. They usually don't ask for the money back, but they are very upset of paying and not having any results. But about 95% of patients, they improve. And I'm sorry about putting huge improvement here. I know this is a not proper scientific way of showing results, but I must say this. These guys are like a mouth-to-mouth promoter of your clinic. That's just amazing. They are forever unhappy with that chronic red eye, and suddenly you improve that as a huge improvement. So this is what I wanted to share with you. I'm ready, of course, for discussions, and I'm sorry if there was any problems with my screen share. Of course, you have my numbers, but it's right here on screen. So I'm ready for your questions. And I'm not sure, Renato, I'm seeing you on the screen now. Are you the one who told me to change from dry eye to tear spa? I think so, wasn't it? Yeah, I think so, yeah.
I think the message of a tear spa is much more related to the spa than to the dry eye, because it's like when you call dry eye, it's the patients who are suffering. And in my mind, everyone who works on the computer has a little bit of dry eye and may benefit from this concept of spa. So it's like if you need a physiotherapy, you have to have severe injury in your knee, it's one thing, but anyone will be benefiting from a good massage and a good care. So the idea is to expand and to really evolve from patients who are suffering for improving quality of life, quality of vision.
Yeah. And you showed a patient, you talk about a patient with paradoxal tearing, and she was amazed. He had not dry eyes. So we have to understand the market has their own way of talking about dry eye. We doctors, we talk about this differently. So we have to respect that. And thank you for changing my dry eye spa to tear spa. A good tear spa, I say. A good tear.
Beneficial, I can imagine. Thank you very much, Dr. Moreira. Great answer.
Any other comments to the presentation? It was really nice to hear also from the business side a little bit. Of course, that's also very interesting for our participants and yeah, for everyone considering to invest in such equipment.
I would like just to stress the point of pre-op for the diffractive multifocal IOLs. I have a lecture that I give forever now, which is the 0.5 diopter challenge. We usually are off about 0.5 diopters, and usually that's on the cornea. Our ability of measuring the cornea is not as good as measuring the actual axial length. So this is improving our ability of measuring cornea. I would say when you get the cornea much better lubricated with a physiological way of lubricating the epithelium, and the thickness of the epithelium is regular and nice, you're going to improve. I don't have any results about that, of course, but that's my feeling. You're going to improve the IOL calculation when you think and you pay attention to the corneal surface as we are seeing now, Thank you.
Thank you very much. Yeah. Oh, yes, here we have already a question. Is there any difference? But maybe Daniel, you can place the question.
1 second.
There was the question if there is any difference between dry eye spa and tear spa. It's the business-wise difference, right?
Well, from the patient standpoint, it's a huge difference.
Yeah.
It's a big difference. And actually, you know, tear spa is something that makes you smile. Dry eye spa makes you sad. Makes you get, it looks like you're getting into those operating rooms where they're going to put needles in your eyes and needles in your arms. Dry eye spa is something like this, but tear spa is something that you're going to improve a lot your quality of life.
Yeah.
Yeah.
And okay, perfect. I think this answers perfectly.
Yeah. I have promoted Sal already to the panel. Sal, are you here?
Yes, I am.
Wonderful.
Hi, everyone.
Good to see you again.
Good to see you again. I will share my screen if that's if everyone.
Sal was also to give you a note. Sal also joined our first user meeting.
Yes.
All right, brilliant, guys. Can you all see my screen?
Yes.
Okay, so quick introduction about myself. So I've had the EI now for about a few months. And so I just wanted to kind of share with you a few of my experiences that I've done. I'll talk about it from a business point of view as well, just to kind of show how I've incorporated it more from an MBA kind of take it up. So I'm actually doing some research with the EI as well. And so I've had some experiences in my dry eye clinic of some patients who I have treated. And for me, imaging for me is such an important thing for me. And I'll talk about why it's so important in terms of with patients, if they can see their glands, they understand like the importance of dealing with the dry eyes. And so this was a patient who came to me at my dry eye clinic, quite severe dry eyes. We did the metrography, and for every single patient when we run our clinic, we do a DEQ5 on every single patient. And we actually did some research in the clinic, in our clinic, to see how many of our patients actually have dry eyes. And we were shocked to hear that on the OSDI score, over 51% of the patients had clinical signs of dry eyes. And that would just, I mean, it's a huge number. So there's a huge opportunity to help those patients. And so in this patient, we do the lid expression. And so we do it with our finger or a bud, or we do also use the MGD evaluator. Now, in this example, I did the IRPL. And when I do my expression, I know it's not required to do an expression post IRPL, but I like to kind of try things out. So I have other devices that I did for my expression. So on this one, I did my IRPL, but then I also did an iLux afterwards, just to see what came out of the glands. And I was shocked to see, I first looked on the slit lamp, and I could see stuff oozing out of the gland, and I didn't even have, I hadn't even touched the gland yet. So I thought, okay, this would be a great patient just to kind of express it and get all the stuff out. And you can see just from the images from here, the amount of expression we're getting from this patient. So this for me was, I've never seen this in my life, to have that much expression coming out from a patient. So I just thought I'd share with you some of my best practices that I've been having since having the IRPL. So in my clinic, we have 3 exam lanes. And so we've incorporated a system where we have it all on a trolley. And so we just move it from room to room and as we need it. So that for us has worked really, really well. I thought I'd show you my little, what I do for each of my patients. I have a tray. And from the last lectures done by Eric, he did a fantastic job of explaining how he does his practice operations. So I thought I'd share with you how I've been doing it as well. So I really like using the tongue depressor. It works fantastic for applying the gel, but also to take off the gel as well. So for me, that's been one of my pearls that I've really enjoyed to do, and it speeds up my application. So we have our tray, we have the goggles, we have the alcohol wipes. I actually make it into an ice bar. So similar to what we talked about before, I'm calling it an ice bar, but maybe I should actually call it a tear spa. And so that's why I really enjoy these opportunities to learn from other people and share best practices. And so I actually use the dental model of way of doing it. So I actually have a hairnet, because I had one of my patients who had really long hair and she didn't tie it back and it got on the hair. So I've now incorporated a hairnet, and on the side there's a dental bib there as well. My other half is an orthodontist, so I kind of use some of her stuff to kind of in my clinic, and I find it works really well. And I even put some music in the background, because I find that it makes the patient calm, and like just to kind of, so that when their eyes are closed, they're not like tense or uptight. So I find for me that's worked really well. What I really like, so I'm based in Canada, and so in Canada we have our reps with IMED, and so I show this to my patients and I say, look, which celebrity do you think you are? And so I like that. It's just a simple way. And so I've actually treated Indian, Chinese, and my rep is actually on grade 4. So I thought I would just show it to you, because I was a bit apprehensive at first doing his treatment, because I'm always with the skin tones being very, very careful. So I just thought to you, I like this use of like showing the patient in it and involving them in it. So I find that works nicely. So what I did, just to show it to you, I actually treated my actual rep. So this is my actual rep doing the treatment. And so I just thought I'd kind of show it to you. And he coped really well. He didn't have any, he didn't complain to me that he was having excessive pain or anything like that, or like not pain, and just like that thing. He did well. If you notice on his eyes, I did put on his molds the tags on there, just to be on the safe side, just to make sure that he was all nice and comfortable. Now, what I do, and I thought I'd share with you, I learned this from an ophthalmologist in the US. And when I express now, I do it on the slit lamp, but I take it from the dental model as well. So I make it into a spa experience. I bring the patient back, and then I express basically as if I'm in the dental chair. And I have loops on, and I have my thing. So it's like a dental experience to me, but we try and make it as enjoyable for the patient. And so I thought Ben, my rep, would be a great patient to actually do this on. And he actually enjoyed it. And so like, he's told me it wasn't that bad. He kind of, and I know you don't have to express post-treatment, but I just like to show it to the patient as well, so that they can see what's coming out and all those clearing of the glands. So I don't do it per se. Now that I've been doing it for a bit longer now, I find that I don't do it on my first 2 treatments. I usually do it on my 3rd treatment now. So I'm playing with when to express, but that for me is something I'm doing as I learn with more treatments. But again, I know with IRPL, it's not essential to express. So that was me doing with the loops. So I basically have loops and some lights, and I basically go and express their glands, and I can do a lid debridement as well. So this is a patient, I thought I'd show it to you. This is a patient I have been treating. I've blanked out her information, and so it's all, and she has agreed for me to show this data. So basically I do a full workup for all my patients before I start my IRPL. And that very much involves doing a non-invasive tear breakup time. So on this patient, we saw her, this was on the 24th of July. And on this diagram, we've got a tear breakup time of around 3.9 seconds in the right eye, and about 9 seconds approximately in the left eye. So I actually saw her Yesterday. So while the presentation was going on, I was quickly trying to bring in the data. So I saw her yesterday on the 25th of August. Again, this is for her next treatment follow-up. And you can see the tear breakup time has gone from, it was 3 seconds. I'll just go back to that slide again. It was 3.9 seconds now to 10 seconds in that right eye. And that DEQ5 questionnaire was showing previously 14 and now at 11. She even told me when she filled it out, she goes to me, I was being a bit on the higher side because I just wanted to see if this really was making a difference or not. And so we're seeing her back at day 75 and we're gonna see how she feels. But she says she feels so much improvement. So I found that quite nice to be able to show the patient that. I think this is a really exciting time to be in ophthalmology and optometry. And so I like to educate the patient with educational videos, and I don't just do the treatment, I send them home with like a post-care treatment of hot compressing, lid wipes, drops, artificial tears, blinking exercises, and we have a free app on the App Store, which just basically tracks their compliance with that and then brings them back for their IRPL treatment at day 75. So we're just integrating that into the app and it's completely free. And so it kind of helps with that compliance so that they know they have to come back. And they can also track their DEQ score via the app as well. And so we found that has helped patients feel as if they are in charge of their treatments and in their dry eye appointments. So we found that has worked really nicely. So I thought, because I know I don't have a huge amount of time, because I know I'm on the last speaker, so I thought I'd keep it quite short. So I just thought I'd share with you from a practice operations, and I really liked hearing from the previous and the other speakers talking about how it's so important to differentiate yourself from others. And so we have everything in our clinic, all the equipment you could think of. And so my take home is that DEQ5 or any OSDI or speed or whatever questionnaire you use, do it on every patient. I find that for me is the most important way. I stain every patient. For me, that's the way I built dry eyes in my practice. Glands, structure and function for every patient. And I can't emphasize how important meibography is. And I am pro all meibography devices. I have about 3 different ones in my clinic. I use them all. I really enjoy them, and I'm always I like trying new stuff out to see which one is easier to use. And I'm excited to hear about the new one that EI is going to be bringing out soon as well. So the TSM, so I'm excited about that. And I discuss treatments with patients, and that's kind of my protocol. And then we can discuss on TFOS, due to stage 1, stage 2, and 3 accordingly. So then that's kind of that. What I'll tell you about, I'm really excited about what's happening in the world. So we're actually using like an AI software as well, which basically does some work with imaging to track how much dry eye spots there are as well. So I would just say that it's a super exciting time. And from a practice operations, I look at it as the more technology you've got to offer your patient, the better it is for you. And I found that I'm very excited with my IRPL. And it's interesting, yesterday mid-treatment I actually had to change the cartridge. So for me, I was like, oh no, at first I was like, it was kind of a funny one yesterday when I was doing my treatment where I had to midway stop and do my treatment. So I was happy about that because I'm now using it so much more in my practice now by triaging the patients. So I've already used my first round, which is pretty impressive for the first a few months of doing it. So yeah, these are some of the things I've used with TFOS just to kind of talk through it. So we do, a lot of the research we're doing moving forward is looking at how we can incorporate it with dry eyes. But yeah, that was my quick few seconds presentation. I know I didn't have a huge amount of time at the end, but yeah, any questions, I'll be happy to answer anything.
Thank you a lot, Sal. It was you are used, I think, to pack enough content in, even if you have a small time frame. No, it was again impressive, I think, also for our participants. And I don't know if we have already questions, but interesting also to see how you experience and how you discover all your opportunities and options with EI. And to see that even if you're already totally equipped in your clinic, that it makes fun and it is exciting to have something, an add-on, like Dr. Moreira also mentioned, to add value, to differentiate towards other competitors or other eye care specialists.
And I would make one more thing. The reason why I find the dry eye market is so, I enjoy it so much treating those patients, because there's so many studies that you can read about the quality of life for those patients. And so I found that, I mean, severe dry eye has been rated as equivalent to angina or a dialysis. And so basically the quality of life for me has been those patients who've had those treatments and they've been at the quality of life score, which is the work to the point where they are now so happy. The change in their quality of life is unbelievable. And so for me, that's why I say that it's such an important thing that we have these things available to help those patients who really are having those issues with dry eye. So I just am so excited to see the opportunities and the new advances that are going to be there in dry eyes to help those patients who are really having those issues.
Thank you. There is.
So I just wanted to inform you, Ben is actually watching, I think.
Oh, is he? Oh, I didn't know that. Oh, fantastic. I did not know that.
Ben, also to you, if you want to maybe quickly share how it was for you as a patient, you're very welcome to. You can just either use the chat or raise your hand so I can give you permission, speaking permission. Anyway, yeah, thanks for the great presentation and thanks for sharing your insights, how you actually do how you have set up your practice and everything. Yeah, Ben is actually writing in the chat, it was great. So congratulations to you, Sal, for performing a great, and it felt amazing, for an amazing treatment.
Many compliments for you, Sal, I read here. But maybe Dr. Moreira wants to add something as he's also back here.
I just opened the camera since I think we are almost finishing, just to thank you a lot for the opportunity. You guys are doing quite a difference. As Dr. Jaraf said, quality of life is something that we have to take care of. And these people many times are miserable. They come from warm compresses and doing every day, taking every night care of that. And this is really different. There are some of these guys that went through this kind of procedure, the treatment, that they are really promoting the clinic, since their results are absolutely different from what they got before. Of course, we don't, since we are doing statistics, there are some that are not like that. But many of these patients are really nice to see the results.
Yeah, absolutely. And as you mentioned, happy patients are the best mouth-to-mouth marketing.
That's right.
Very often it's confirmed. I remember, I don't know if Luca Vigo is today in the participants. He just came back also from his holidays, but I remember he was our first user in Italy. And when I first visited him after a couple of months, he mentioned, it's so funny, I do not have yet a video or something else to present in my waiting area, but people are talking together why they are here. And so they are maybe with another appointment booked and waiting in the waiting room, and then they ask for an appointment for the treatment as they discussed patient to patient in the waiting area. So happy patient, of course, I think as well, same for us as a manufacturer. For us, it's not done once a device is sold to our partners, to our distributors, or installed in one of your clinics. For us, the line is complete if at the end of the chain, a happy patient is happy with his quality in life and daily comfort in his vision, and that's the most important, I think.
Yeah, and I think with that being said, we are going to close the session. Thank you. I know it's a little bit later than that originally planned, but thank you to all our speakers for taking the time to prepare the presentations and for taking the time to share your experiences and your knowledge. And also, of course, thank you to all our participants. Almost everyone stayed until the very end now. Thank you. It was again very, very nice meeting you all, and a very nice lecture, also for us to get to know even more how people are using our devices, and thank you.
So I can only add on that we will be back in September with next user meeting and with next news, I would say. Okay. Thank you all of you for your time and for your engagement. Goodbye.